Hi, good evening. From the organizers of Covai Heart Rhythm Summit 2021, we welcome you all.
Good evening. A warm welcome from Covai Heart Rhythm Summit to all who have chosen to breathe in academic air this Saturday evening. CHRS is an event which has been happening once every year, and this is the 6th edition. Devoted strongly to academics in cardiac electrophysiology, this program has grown in content over the years, and here it is this year again as a much welcome hybrid meeting after going completely virtual last year. As we have here an irresistible lineup of talks, let me not take much time before we go on to the first academic session for the evening. There are 2 talks in the first session. At the end of each talk will be a discussion on the topic by an esteemed panel. Each and every one in the audience is invited to post their queries in the Q&A column on the stage page, and they will be discussed by the panel, that way making it a lively and interactive event. The moderators for the first session are Dr. Dilip Kumar from Kolkata and Dr. K.A. Sambasivam from Coimbatore. The panelists for the first session are Dr. Mariyappan from Salem, Dr. Pacheppan from Salem, Dr. Murugan from Erode, Dr. Arvind Kumar from Trichy, Dr. Krishna Kumar from Salem, and Dr. Kesavan from Karur. The first talk, Contemporary Management of Atrial Fibrillation and Update, will be by Dr. Rajeev Pathak. Dr. Rajeev Pathak is the clinical and academic lead of cardiac electrophysiology at the Canberra Hospital. His training in cardiology was at the Canberra Hospital before subspecializing in cardiac electrophysiology at the Royal Adelaide Hospital. During his clinical training under Professor Prashanthan Sanders, he completed PhD through the University of Adelaide in 2015, for which he was awarded several accolades and awards. Dr. Pathak has been honored with Young Author Achievement Award, Doctoral Research Medal, and Dean's Commendation, and many other awards. In 2017, Dr. Pathak was appointed as a clinical lead for cardiac electrophysiology and pacing at the Canberra Hospital, and has established the electrophysiology services at the Canberra Hospital to provide specialized care for cardiac arrhythmias. I now request the moderators to take over the proceedings for the session.
Hi, good evening. A warm welcome to everyone. I wish the function a great success, Dr. Lawrence. Without much ado, I would like to invite the first speaker of the talk, who is going to give us a talk about the update in the management of atrial fibrillation, Dr. Rajeev Pathak. I think to introduce Pathak is already done by Dr. Albina. So over to you, Dr. Rajeev.
All right, guys. Can you guys see me? Hello.
Yeah.
Good evening, everyone. This is Rajeev Pathak calling from Australia. Thank you, Lawrence, for this kind invitation. The topic today is to discuss about atrial fibrillation management and to discuss about latest update which we may have. Atrial fibrillation, we understand, is the chaotic activity which happens in the atria in the upper chamber. This can be because of the triggers and can also be because of the overall substrate a patient develops. And while in a normal sinus rhythm, you have an organized activity with the electrical impulses generated from sinus node leading to electrical contraction in the atrial chamber. There is a disruption of electrical impulses. And finally, either from the pulmonary veins triggers, which causes the atrial fibrillation, or the substrate around, which finally results into this chaotic atrial activity. And therefore, there is lack of synchronized atrial contraction, and there is no atrial contraction happens there. And that's what we call as atrial fibrillation. Now, when we talk about the management of atrial fibrillation, which is the most important focus I'll have in the topic, rather than trying to discuss about the different mechanism behind atrial fibrillation, the management of atrial fibrillation, there are 4 major pillars. The first pillar is anticoagulation. The second is rate control strategy. The third, rhythm control strategy. Last but not least is risk factor management. All these four are extremely important management strategy, and most important among them is also patient education and engagement. Now, the compliance is extremely important in management of any chronic condition, and atrial fibrillation is a chronic condition. Compliance of a patient depends on their education, their understanding of the disease, and with understanding of the disease comes the engagement. And therefore, education and engagement remains cornerstone of foundation based on which all the four different management strategies should be started. To the first and most important is anticoagulation. We all know that atrial fibrillation, there is a chaotic atrial activity and lack of synchronized atrial contraction that leads to blood stasis, which leads to increased risk of stroke. In atrial fibrillation, when there is a stroke, not only those strokes are associated with a greater disability, it also leads to mortality. And therefore, anticoagulation with blood thinners such as warfarin or novel anticoagulant agents has been shown to reduce risk. To start those anticoagulation, we have guidelines, and this is paper from Gregory Lipp, which was in 2010 published, looking at various risk factors a patient may have, which increases risk of stroke. And based on those, we can decide if patient should or should not be on anticoagulation. Risk factors such as congestive heart failure with ejection fraction less than 35%, presence of hypertension, age, diabetes, history of stroke or TIA, vascular disease, or age greater than 65, all of them have they are important risk factors. Female sex used to be, and recently that has been taken out, almost what we call as sex-less Chatsworth score of prediction of stroke. We all know greater than 2 or 2 risk factor, those patients definitely should be on anticoagulation. If you have 0 risk factor or 1 of these risk factor, there is still some debate, some confusion whether these patients should or should not be on anticoagulation. Now, it's important for listeners and viewers to understand that while this is a guide, there are certain other risk factors which did not make into this Chatsworth score, which may still be relevant. Some of the important ones are burden of the atrial fibrillation itself, volume of left atria, presence of metabolic syndrome, all those different conditions which may have to be taken into account. Additionally, what is important to understand that while each of these risk factors, they carry risk, not all of them are similar. Age greater than 75 and history of a TIA stroke, of course, increases risk of having stroke considerably. The other risk factors such as diabetes, hypertension, all get 1 point if you have them. But what I'm going to suggest is I don't think we should see each individual risk factor as a binary presence or absence. And in fact, they should be seen as an incremental risk, even in that particular risk factor itself. So while a good control of blood pressure with the excellent control, less than 120 systolic blood pressure most of the time, there will be a reduced risk of having stroke. A poor control of blood pressure, with the blood pressure persistently remaining elevated, has a greater risk of having a stroke. Similarly, the duration of a particular illness itself also increases risk of stroke. A patient with no diabetes, of course, has lesser risk of stroke. And if the diabetes diagnosis is recent, it has been shown that the risk is lower. While if the diabetes risk remains, diabetes has been there for greater than 3 years, if the patient have poorly controlled diabetes, if they are insulin-dependent diabetes patients, of course, the risk of stroke in those patients are greater, despite they only getting CHA2DS2-VASc score of, for diabetes only. Now, from there, I'm going to move to the second pillar, which we talk about, is the rate control strategy. One of the greater risks of atrial fibrillation is tachy-mediated cardiomyopathy. When these patients have chaotic atrial activity, some of the electrical impulses can go uninhibited from the AV node, resulting into faster ventricular rate and can lead to tachycardia-mediated cardiomyopathy. So when we look at the management plan, there are two different ways you can try and achieve rate control strategies in these patients. You can have medical therapy, or you can consider doing an AV node ablation. In medical therapy, you have medications such as beta blockers, calcium channel blockers, or digoxin, which can be given to try and get a rate control. Most of the drugs are going to work on AV node, reducing the electrical impulses going into the ventricle, thus controlling the heart rate, and that can lead to reversal of heart failure. While these drugs are generally well tolerated, unfortunately, most of the elderly patients may not tolerate these drugs because of the either side effects or the adverse effects of the medication, such as calcium channel blockers. They can drop the blood pressure, can cause constipation, and therefore patients may not tolerate the medication. Again, it's important to realize some of these effects may be temporary, or say if a patient was a 50 or 60-year-old and these patients were started on these rate control medication, and over the years they become elderly, they may not tolerate these medication while they were tolerating them really well when they were younger. So then comes the strategy of pace and ablate. So in this, these patients get a pacemaker, and these pacemakers can be either a single lead pacemaker or a CRT system. And once the leads are placed, then these patients can have an AV node ablation. And after AV node ablation, almost certainly these patients will mostly always remain in atrial fibrillation, whereas the ventricular rate is going to be controlled by the device itself. To summarize, these patients will have a lead into the right ventricle and left ventricle, and then they get an AV node ablation, and finally that result into a proper synchronization of the ventricular contraction, and of course the pacemaker controls the rate while this patient remains in atrial fibrillation. And that is a permanent way to control the rate in these AF patients. The only caveat will be that their heart rate, of course, depends on the pacemaker. The next pillar for AF management we should discuss will be rhythm control strategy. And our rhythm control strategy can be medical management or by catheter ablation. There are three main medications which we can use for rhythm control strategy. They can be drugs such as antiarrhythmics, flecainide, can be sotalol, or can be amiodarone, which can be used. Of course, amiodarone is the strongest medication, unfortunately, can lead to terrible side effects, and this should not be seen as a medication to be given in long term because of its side effects. And if a patient is given that medication, careful, vigilant monitoring of their lung function, of their thyroid function, and liver function should be instituted. That brings us to talking about the catheter ablation. The HRS guidelines, the recent guidelines, talks about AF ablation, and it can be considered as a first-line therapy. The primary indication still remains in a patient with symptomatic atrial fibrillation, refractory or intolerant to antiarrhythmic medication. Catheter ablation procedure should be offered to these patients. There are certain clinical situations in which AF ablation can be offered as a primary or first-line therapy, and those patients could be either patients with heart failure with reduced ejection fraction, or someone who do not want to take antiarrhythmic medication in the long term. Now, there's no doubt that when we compare antiarrhythmic drug with catheter ablation has been shown in paroxysmal atrial fibrillation with a better control of atrial fibrillation. Now, this is the study from 19 Center, which was published in 2010 by Dr. David Wilber, and it shows a dramatic difference in long-term AF control and management in catheter ablation group in comparison to antiarrhythmic medication. Now, recent studies such as Cabana has shown that there may not be a mortality benefit, but most certainly that patients after catheter ablation had greater freedom from atrial fibrillation. Now, this is our data for 650 procedures we have done in last 4 years, and we found a single procedure success in our patients are around 75 to 80%, and multiple procedure, the success goes up to 85 to 90%. With a little bit more ablation, like ablation for left-sided flutter, the success can be anywhere around 90 to 95% at 4 years mark. Now, there's no doubt pulmonary veins are the main trigger site for atrial fibrillation. That's where most of these triggers are coming from. And this was described by Michel Hesseguer in 1998. And we found that most of these triggers are coming from these thoracic veins. Pulmonary veins are the commonest. Superior vena cava and near the coronary sinus and Eustachian ridge can be other areas where these atrial fibrillations are coming from. Now, various different strategies have been developed over the years by different groups to try to achieve the similar results. Michel Hesseguer discussed about pulmonary vein isolation, and it was individual vein isolation, which he described. Then Dr. Cook described en bloc or wide circumferential pulmonary vein isolation of both, including at the same time. Papone's group talking about having the coronal lesion, and Natale talking about ablation, along with posterior wall isolation, and trying to talk about the cafe ablation as well from Nadamani group. Now, recent paper from Atul Verma from 2015, actually it's not recent anymore, shows even in persistent atrial fibrillation, even today, pulmonary vein isolation has shown to have the best outcome. Anything extra, cafe or line ablation has not shown to have any incremental benefit. There may be benefit in certain subset of patients, but overall group, pulmonary vein isolation still remains the mainstay for AF ablation, both for paroxysmal and persistent atrial fibrillation, and any further ablation should be individualized and should only be offered in a certain subset of patients only. Now, this is our data, as I talked about. This has also been shown in Cabana, that one of the most important message to take actually from Cabana was that AF ablation procedure over the years have become extremely safe. And this is our data of 650 patients. Look at the complication rate. The complication rate is less than 0.001%. We had one patient with tamponade, 0 stroke, no fistula, no pulmonary vein stenosis. 5 patients has pericarditis, and they had small pericardial effusion. None of them had any hemodynamic compromise. We had 0 death among all our patients who had undergone AF ablation procedure. So the most important message is that AF ablation procedure has become extremely safe. With the advent of 3D mapping system, magnetic navigation, better monitoring, better catheter tip technology, this procedure has become extremely safe and can be safely offered as a first-line therapy for the patient. There are certain subset of patients where catheter ablation not only has shown a benefit from arrhythmia reduction and quality of life, has also shown mortality benefit. And this was shown elegantly by Dr. Marouche group in Castle AF patients. where AF ablation was shown to not only reduce the AF burden, improve the quality of life, but also was associated with reduction in mortality and hospitalization. So in this subset of patients, no doubt AF ablation should be offered as a first-line therapy. When we do an AF ablation, we normally like to have about 8 weeks of blanking period, and general physicians and cardiologists, it's an important message to have that those 8 weeks patients can experience some palpitation, and that doesn't mean that the procedure was a failure. That's just a normal reaction when you have burnt and done an ablation, that they can have these short runs of atrial tachycardia. These patients, we normally like to follow up in about 3 months, 6 months, 12 months time, and thereafter once every 12 months. It is possible that post-ablation, these patients will still remain on antiarrhythmic drugs for up to 3 to 6 months, and that should again not be seen as a procedural failure. Sometimes these patients have advanced substrate, and medication helps us to maintain sinus rhythm, and slowly these medications will be weaned off. Post-AF ablation, there is a possibility that these patients may still have some atrial fibrillation, and the target may be in certain subset of patients to get a 95% reduction in their AF burden rather than trying to achieve a complete freedom from arrhythmia. Some of these patients will end up with atrial flutters, and they can be atypical flutters, either because of small reconnection in the pulmonary veins, which are ablated. And the procedure can be fairly simple, going and mapping the left atria and blocking off those connections, or could be sometime mitral annular flutter, where additional lines may have to be drawn. The discussion, I don't want to go into the details of this, which is a separate talk altogether, but I just wanted to give a broad overview of that. Monitoring of these patients are done with Hold to Monitor, or you can put an implantable loop recorder, and which helps us to be able to then monitor these patients' atrial fibrillation. This now brings me to the last topic of the AF management, which is about the risk factor itself. Now, atrial fibrillation should be seen as an end organ damage because of the risk factors these patients have. Presence of hypertension, diabetes, use of excessive amount of alcohol, smoking, dyslipidemia, coronary artery disease, all these different risk factors result into a substrate. And these substrate then finally lead to atrial fibrillation. Will start as a trigger, an paroxysmal atrial fibrillation, and then subsequently become a persistent and a long-standing persistent atrial fibrillation. And therefore, management of these cardiac risk factor is one of the central stone in the management of atrial fibrillation. Now, not only presence of each individual cardiac risk factor is important, sometimes presence of an additional risk factor increases risk of atrial fibrillation dramatically. Most of these cardiac risk factors keep each other's company. Patients with high BMI, as we can see in the paper here, what we see here is BMI of less than 25 in orange, 25 to 30 in blue, and a gray with the BMI greater than 30. And then, as we can see, with increase in BMI, there is increased risk of atrial fibrillation. However, it's again important to see here in the x-axis where you have AHI score, which is marker of sleep apnea. And as we go towards the right, there is a higher AHI score suggestive of a severe sleep apnea. And we see that with obesity and presence of sleep apnea, the risk of atrial fibrillation is quite dramatic and can be exponentially high. And therefore, management of these cardiac risk factors is extremely important in overall management of atrial fibrillation. We looked at this data. We looked at the importance of aggressive risk factor management in management and implication of this management on ablation outcome. What we found that patients who underwent aggressive risk factor management at 2 years mark, 62% of the patients were free from atrial fibrillation after single procedure. And only 26% of the patient remained free from atrial fibrillation if they did not manage the risk factor. Similarly, after 2 or 3 procedures, if they had aggressive risk factor management, nearly 87% of the patient remained free from atrial fibrillation, and only 50% of the patient remained free from atrial fibrillation if they did not manage their cardiac risk factor. Therefore, showing in a patient undergoing catheter ablation, it's extremely important that we manage their cardiac risk factors. It improves our overall outcome data. We also looked at in patients with BMI greater than 27, if management of cardiac risk factor and weight loss with a goal-directed weight loss management program, if that had any long-term benefit. This graph shows the outcome data from AF freedom without catheter ablation or any antiarrhythmic medication. What we see here in the orange curve is the patients who ended up losing 10% weight. And what's important to realize that at 3 years mark, we see nearly 50% of those patients who were referred to us for catheter ablation. If they lost 10% of their weight, they remained free from atrial fibrillation without any catheter ablation, and they were also not on antiarrhythmic medication. This really highlights the importance of weight loss in these patients who are obese. We also looked at importance of aggressive risk factor management. We looked if they go through a structured exercise program, if that has any long-term benefit in management of atrial fibrillation. We found that patients who undergo structured exercise program, 61% of those patients remain free from atrial fibrillation without any catheter ablation or a medication, antiarrhythmic medication, while only 18% of the patient remain free from atrial fibrillation if they continue to gain weight, they did not address their risk factors, and their exercise capacity continued to decline. Now, we know that atrial fibrillation is a progressive disease. That disease from the time of diagnosis becomes paroxysmal, persistent, and permanent. Presence of cardiac risk factors has been shown to be associated with increasing progression of the disease, and presence of more cardiac risk factor increases this progression and makes the disease become more permanent. Now, we have looked at this data, and addressing these cardiac risk factors, we have shown that the disease process can be halted, and not only halted, in fact, can be reversed. A persistent atrial fibrillation patient can become paroxysmal, and a paroxysmal atrial fibrillation patient can become free from atrial fibrillation if these risk factors are addressed in these patients. So, what we suggest in our patients with atrial fibrillation, a dedicated, tailored clinic where these patients are offered weight management, their cholesterol and lipid profile is managed, their glucose tolerance is tested, and their HbA1c is monitored. They're given a target blood pressure. They are given ACE inhibitors and ARBs to try and get the blood pressure less than 130/80. All of them go through a formal sleep study, and if they have sleep apnea, they are given a CPAP machine. Smoking cessation and reduction of alcohol intake less than 30 grams per week is the target. Additionally, they are given a structured exercise program. The frequency, the intensity, the time, and the type of exercise is prescribed to them, and they are advised and encouraged to use smartwatches so that we can monitor their heart rate and try to increase their exercise capacity. With the structured exercise and diet and lifestyle modification program, these patients can have a far greater freedom from atrial fibrillation without antiarrhythmic medication or without catheter ablation. And if they end up needing catheter ablation procedure, their outcomes are going to be better anyway. So that summarizes all the 4 pillars of cardiac risk factor management, ladies and gentlemen, I'm going to stop my talk here by saying in AF management, it's extremely important to understand this is a disease because of the risk factors a patient carry. And it's important to look at all the four pillars, the anticoagulation, the rate control, the rhythm control, and risk factor management to try and give them overall care of the treatment. I want to stop here and thank you very much. And I'm happy to take the question now.